Good afternoon, everyone. My name is Anita Champagne, and I'm the division chief for genetics, but it's my pleasure today to announce and welcome Dr. Alicia Latham. So Dr. Latham is a South Carolinian, and so it's exciting to have her back in our state. She actually graduated from MUSC, and I had the pleasure of meeting her when she was a resident at Self Regional in family medicine. She's gone on to do a residency in genetics, and she currently works at the Memorial Sloan Kettering. She's doing a lot of preventative work, and I'm excited for her to come and show all of the great and exciting research and activities that she's been doing for 10 years now? Awesome. So welcome, Alicia.
What are you doing today?
It's nice to be back, and I have to tell you, I have had a lot of coffee. So I have my little meter here. Her name is Anna. She is a fabulous cancer genetic counselor that I work with. So if I'm talking to you fast or too slow, let me know, but she'll help me as well. So the title of this talk, and I kind of played with this a little bit, but I think where I landed was because I really, my career path, I'm not an oncologist, full stop. I do not treat cancer, and I've never really wanted to treat cancer. I've wanted to understand a couple of things. One, how can we detect it early? And two, how can we prevent it? And I think that everyone is kind of looking at this space in ways that we can do this. And a perfect model is hereditary cancer susceptibility. So to start that off, just kind of looking in general, this little pathway here when we're thinking about the care of a patient as they walk through and go through a tertiary or quaternary cancer center. So when you think about precision oncology and interception, it really is a continuous process, and genetics touches all of this. You guys know this better than anyone. Genetic counselors, every single time you're involved. Yes.
I didn't see you online yet. Hold on 1 second.
Oh, no.
It was too good to be true.
Oh, that's okay.
Sorry.
You're okay.
Okay, there we go. All right.
Okay, now they got it.
Yep.
Okay, excellent. So, essentially, as a patient walks through this pathway in the care of their cancer, genetics touches all of this. And in general, even at Memorial, we've really excelled with this left half, the patient's treatment journey through genetics and how we can intervene. They have cancer, they're looking at pre-surgical decision making, then they're deciding oncologic treatment. We're really looking at. Given my background, my work really focuses on two key areas here, and that's surveillance and survivorship, along with our family risk. And I think that hereditary cancer genetics and these predisposition syndromes are excellent models for understanding cancer in all patients, because it's kind of thinking about this through an accelerated process. When you think about this in general, most, not all, but most hereditary cancer predispositions are caused by germline or heritable mutations and tumor suppressors. So this is my fun cartoon. These are my little race cars. So we're thinking about normal genes that regulate cell growth and death. You get that first mutation, you're thinking about susceptibility. This is risky. So I'm thinking about these oncogens, and you're really stepping on that gas. And when you have the second loss, you put on the gas and no brakes. That's when cancer really develops. We have many systems in place to prevent and/or fix these DNA errors, such as the ones listed here: homologous recombination, base excision, nucleotide excision, et cetera, et cetera. My career has really, for the most part, focused a lot on the mismatch repair system, which I'm going to talk about quite extensively. So just to orient you, the DNA mismatch repair system, I think of this as the body's spell checker. And I also think of it as a little bit of autocorrect. And for those of you that are not familiar with him, although I hear he is coming back, thank you, Microsoft, this is Clippy. Clippy is my representation of MMR. So really what we're talking about is this DNA mismatch repair system. How this works is when you're thinking of scanning the genome, trying to understand, you have these four or more genes that work together as a buddy system to try to look for DNA damage. So they're scanning, they're looking, okay, where are some insertions or deletions? Let's fix that mismatch. When someone does not have a working mismatch repair system, they have a germline mutation in one of these genes, what happens is that spell checker is not working adequately. So these insertions may continue, and so they have lengthening, or they may shrink, so a deletion may come. And so what happens is that these tend to happen at these loci that are called microsatellites. Microsatellites are just repeat sequences throughout the genome. They're supposed to be consistent. And when they're not consistent and you don't fix them, you get something that is referred to as microsatellite instability. So in the now cancerous tissue, it's just the variation in the lengths of those segments in the cancerous tissue compared to the normal. And that is a key feature of Lynch syndrome. So Lynch syndrome is the syndrome that is caused by germline mutations in these genes. We previously called it HNPCC, some still do. I don't, because for a couple of reasons. One, I cannot stand saying hereditary non-polyposis colorectal cancer. It's way too much. Two, we changed this to honor Henry Lynch, who was a pioneer in understanding these families. And we know that this is associated with colon cancer, endometrial cancer, endometriosis associated ovarian cancers, and other GI cancers. But we do know a little bit more now. This is definitely more common than we previously thought. When I was in medical school, I remember being taught 1 in 1,000, then 1 in 500, and now our best risk estimate right now is 1 in 279. What's most striking, however, is that 95% of people that have a mutation in one of these genes don't know that they have it. What's important to understand about Lynch syndrome is that colorectal cancer develops via a rapid progression pathway. So on the top here, when you're thinking about the typical process of colon cancer development, you have your normal epithelium, then you get things like APC tumor suppression loss, you might get small benign polyps, and then it goes to this cascade. And this is slow. This takes about 10 years for this to occur, which is why colonoscopy recommendations for the general population are approximately every 10 years. In Lynch syndrome, you have a rapid progression pathway. And one of the most I think the hypothesis and what we've seen more often than not in terms of explaining this is that these MMR deficient crypts in normal tissue start having a different types of mutation cascade and pathway. And so this happens quite quickly. And this progression can happen very fast to the point where there are clinical implications. So people that have Lynch syndrome are recommended to have colonoscopy every 1 to 2 years compared to every 10. In general, Lynch syndrome recommendations, these are old NCCN recommendations. So historically, we lumped all Lynch syndrome together. We know that's not necessarily the case anymore. But the thing that I really want to highlight here is that despite all of these recommendations in terms of pure screening, the only thing that has been proven to be effective for cancer screening in Lynch syndrome is colonoscopy. Everything else, we're doing our best. So that's not great. We've been around for a while, but we still only have that as the proven effective screening. In terms of how this relates to other patients and kind of where I'm going with this, we know that the inherent underlying defect in Lynch syndrome is the fact that they have a germline predisposition and a mutation in one of these genes. So mismatch repair deficiency in a tumor and microsatellite instability are hallmarks of Lynch-associated cancer. Many years ago, and to this day, the PCR-based MSI assessment, and then certainly IHC for mismatch repair deficiency, were historically used to assess tumors. And it's been part of universal guidelines for endometrial and colon cancer to assess all of these tumors for this finding to then assess for underlying Lynch syndrome. Then things changed. In 2017, this paper was published. It kind of changed everything in terms of understanding precision oncology with MRD. So these tumors, we know that it predicts response to PD-1 blockade. So I am not a part of this paper at all. This is Luis Diaz and group's work. What they essentially found was in a small study, relatively, it was 86 patients in this original science paper, 12 different tumor types. About half of them had Lynch syndrome. All of these patients had had prior treatment with progression of disease at their study enrollment before getting PD-1 blockade, and they used pembrolizumab. Their tumors were determined to be either mismatch repair deficient by IHC or MSI-PCR. And they saw an objective radiographic response in over half of them and a complete response in a fifth of them. That seems small on the initially, but these are all patients that had progression of disease before. So this was a huge paper, which then started this whole idea of, wow, if we're seeing this response to immunotherapy, how can we utilize that tool and expand this to more patients? So at Memorial, the way that we do genetics, the vast majority, is through our MSK Impact protocol. So that's what it stands for. Everyone likes acronyms. But essentially, we've done this for quite some time, since 2012. This is paired tumor normal sequencing. Patients may either consent to just the somatic or tumor sequencing portion, or they may also consent to have their germline unmasked. Most people consent to both parts. In 2015, we integrated next-gen sequencing for MSI calling via MSI sensor into our tumor platform. And so this is essentially a bioinformatics algorithm that reports the percentage of those loci, those little repeat sequences throughout the genome in the tumor, reports it as a cumulative score. If you have an MSI sensor score greater than 10, that is a very, very high, that's an MSI high tumor full in. If it's less than 3, then that's an MSS tumor. And then we have this middle portion. So the idea, and that we call that MSI indeterminate. So that's been going on for quite some time. That brought a question. And the question really was, if we're doing this on all of our tumors, what is the MSI prevalence pan-cancer? Because no one knew that. What is the underlying Lynch syndrome prevalence in MSI tumors pan-cancer? Because we did not know that. And could we characterize germline findings of underlying Lynch by if they were causative versus incidental? So that prompted a study that we did. It was published in the JCO in 2019. We looked at over 15,000 solid tumors for the MSI status, and it covered greater than 50 cancer subtypes. You can see them here on the bar here. We determined underlying Lynch syndrome status across the entire cohort. We found that 50% of patients with Lynch syndrome that had an MSI high tumor presented with a non-colon or endometrial cancer. That hadn't been published before. That was very interesting. So these are patients that wouldn't necessarily, one, have been assessed for MSI status historically, because that wasn't universally done. So they could potentially benefit from immunotherapy and did. And two, they probably wouldn't have been tested for Lynch syndrome. So this was something we were quite struck to see. What we also did was, because in our MSS cases, our 14,000 microsatellite cases, we really wanted to try to understand, what is the prevalence of Lynch syndrome there? Is this causative, et cetera? So we looked at tumor signatures. And in patients with MSI tumors, we found the mismatch repair deficient tumor signature in the vast majority of cases. In patients that had MSS tumors, the vast majority did not have the MMRD tumor signature, pointing to the fact that even though you found Lynch syndrome, it probably wasn't driving that patient's tumor. Most of the mutations were in the MSI tumors were in our high-risk MLH1, MSH2 genes. That makes sense. The majority in MSS group were found in PMS2, MSH6. That is something that has been now reported over and over again, that you can honestly pick up a lot of incidental PMS2. I'm sure all of you, maybe in your breast panels or whatever, you see this incidental PMS2 finding. That makes sense, because PMS2 doesn't seem to be as high risk. It doesn't necessarily mean that it's causing the cancer from which they've presented. Here, because we were curious, our overall Lynch syndrome prevalence in our MSS group was 0.3%. We just did population screening. That's the Lynch syndrome population prevalence. So research also informs patient care. So Lynch syndrome is pan-cancer. an MSI high tumor, regardless of tumor origin, should prompt consideration for Lynch syndrome testing. And that was the big punchline from the JCO paper. So in going back to this, so we now know, we have a favorable prognosis for mismatch repair deficient colorectal cancer. We've known that for some time. And, despite that rapid transformation. And really what that means from a clinical perspective is that patients that have MMRD colorectal cancer, if they're at stage 2, they may be spared chemotherapy, which is a big deal. They may be cured by surgery alone. What about other tumors? So we didn't know this. Could this be the same for other GI cancers, such as small bowel? So we looked at our small bowel group here, and we found that mismatch repair deficiency and Lynch syndrome are frequently found in small bowel cancer. And the clinical implications are similar to those in colorectal. And something that I thought was very striking when we looked at this was, of our small bowel cancers that we found, in our, we about a quarter of them were mismatch repair deficient. About 40% of those had underlying Lynch syndrome, which is pretty striking. Compared to when you look at colon itself, it was about 16% in our data had underlying Lynch, and of those, underlying mismatch repair deficiency, and of those 19% had Lynch. So it was more predictive than even colon. Other key things here is that of those that had mismatch repair proficient disease, they were metastatic at diagnosis compared to those that were mismatch repair deficient. Could this be people that were undergoing high-risk surveillance and they were, plugging in? We don't really know all of that, but there could be a confounder there. The vast majority of the proficient tumors recurred compared to only 18% of the MMRD small bowel. So again, that mismatch repair deficiency is important in terms of a prognosticator. So then the question comes, okay, well, what if you already know the patient has Lynch syndrome? Should you still check their tumor? Person comes in, underlying Lynch syndrome, gets diagnosed with colon cancer. Do you check their IHC? Do you check their MSI status? I would argue the answer is yes. And the reason for that is really a question that was posed by one of our genetic counselors, Megha Ranganathan. Our genetic counselors at MSK are highly involved in our research endeavors, and this was a question that she had. And it's, are all colorectal cancers and Lynch syndrome patients MMRD? And what does that mean? And so this is her data. And essentially what we found is that 10% of our colon cancers in Lynch were mismatch repair proficient. 90% of those proficient tumors were in our lower risk genes, so probably incidental to the Lynch. And what was really interesting was that nearly half of colon cancers among PMS2 mutation carriers were mismatch repair proficient. Now, these are small numbers, but it's still quite interesting to note. And so then the question becomes, what does this mean for treatment? Really, it's that treatment decisions are based on tumor status, not germline. Mutation, and from the genetic counseling standpoint, we are very careful when we counsel our patients, and that mutation negative first-degree relatives of Lynch syndrome patients that have a presumed sporadic colon cancer may still have elevated risk. So if you have a patient with Lynch syndrome, a PMS2 mutation, but their tumor was mismatch repair proficient, right now we can't say if that PMS2 mutation drove that cancer. So their mutation negative patient or sibling might still need higher risk screening. In terms of kind of how guidelines have evolved, you can see these with NCCN. I kind of alluded to the fact that we are now understanding that this is not just one syndrome. It's across using multiple genes to really understand. And so the first attempt at kind of answering that is in this slide with the NCCN and how they changed guidance. This was in version 2, 2023, where they first, tried to separate this out by risk. And so they changed their guidelines in terms of colonoscopy. So they actually now say that colonoscopy every 1 to 3 years and MSH6 and PMS2 mutation carriers could start as late as 35. That gave us a little bit of pause. So we looked at our data. So in terms of MSH6 and PMS2, the real question here, and the thing that I was most concerned about with that change, is that colonoscopy is the only thing we have right now that is proven effective screening in these patients. And so what we wanted to know is how many of our patients at Memorial were diagnosed with early onset cancer in the setting of MSH6 or PMS2. So we did a pan-cancer look, and we subdivided these tumors. So we did Small bowel cancer, urothelial, pancreas, gastroesophageal, ovarian, endometrial, and of course, colorectal. And this chart is just showing their age of diagnosis here. All these little dots are individual patient tumors. And you can see they're also divided by overall tumor and then their mismatch repair MSI status to see if the Lynch syndrome was actually driving it. So you can see here in the small bowel, again, all of these small bowel tumors were mismatch repair deficient, which is pretty compelling. And again, this is just limited to MSH6 and PMS2. What was most striking was our colon cancer, and that's that we found that 16% of our colorectal cancer patients were diagnosed under the age of 35. We don't want to diagnose colon cancer at 35 in a Lynch patient. We want polyps at 35 in a Lynch cancer patient. So given the idea that 16% of these tumors were diagnosed, cancers were diagnosed under age of 35, what do colonoscopies find? So we worked with Dana-Farber and UPenn on trying to put together some data of colonoscopy procedures. We published this last year. And so we looked at 285 patients with Lynch syndrome that were having, with MSH6 or PMS2 Lynch syndrome, that were having colon surveillance at one of our 3 institutions to really try to see what is the pickup rate on these surveillance scopes. And this is a lot of data to look at in terms of graphic representation. But essentially what we found was that in our young patients, because we limited this to patients 50 and younger to see what these findings were, across 824 pooled procedures, a quarter of them had neoplasia, including about 3% with advanced adenomas. We had 5 patients that had advanced serrated lesions and 34 with colorectal cancer. When we stratified that by age at time of procedure, we had a 13% neoplasia before the age of 30, including 3% with colorectal cancer. So it's still striking. So it's still Lynch syndrome. So then that got me to the question, well, here's all the young patients. Everybody's talking about early onset cancer. What about geriatrics? This is a lifelong syndrome. What do you do with elderly patients? How do you know when to stop? We don't even really have great guidance of when to do that in the general population. We have USPS TF, or the Postal Service is what I call it. I can never actually say it. Recommendations, but in terms of how to do this in high risk, we don't have that. So we looked at our patients. This was another collaborative effort. This was with Ohio State and UPenn, and then us, and we looked at our patients, our older patients over the age of 75 with Lynch syndrome to look at complication rates and pick up to try to answer a question of when should you potentially stop screening. So as a reminder, colonoscopy or CRC screening selectively recommended in patients 76 to 85 and not recommended at over the age of 85. We don't have any guidance on geriatric Lynch patients. What we applied to look at our data was what was previously published in surgical literature, and that's the MSK-FI score. It's a frailty index, taking into account medical comorbidities, ADLs, those kinds of things to understand what is the possibility of having a complication. And so we applied that to our colonoscopies across the 3 institutions in these patients. We had 4 major complications. It was a CVA, a post-procedure bleed, significant urinary retention that required hospitalization, and then there was a VTE after someone's anticoagulation was held. However, we did pick up 45% neoplasia, including 7 colorectal cancers, which is interesting. And then the median MSK-FI score was different in patients with complications versus not. We're in the process right now of looking at this in a larger cohort and also expanding to age 65 to really try to give some guidance to gastroenterologists to know when to stop scoping these patients, when that risk outweighs the benefit. So really the idea here is that perhaps the Lynch syndrome gene penetrance and utilization of some sort of frailty index may help with individualized decision-making for these patients. So key points so far. Suspect Lynch syndrome when you see an MSI, colorectal, or endometrial cancer. But 50% of patients will present with something other than MSI, colorectal, or endometrial cancer. Lynch syndrome patients have MSI tumors, except when they don't. MSH6 and PMS2 associated Lynch syndrome may be lower risk, but it's still Lynch syndrome. Lynch syndrome is associated with early onset colon cancer, but you can still present with a colon cancer over the age of 75. This stuff is hard. Managing patients at hereditary risk is complex. We know it's a pan-cancer syndrome. How can we really increase patient education, awareness, adherence to recommendations for screening and risk reduction? So that's where this program comes in. This is my baby, MSK-CATCH. I say it's my baby, but actually our patients named this. We had a working group with our patients and marketing. That was kind of an interesting thing. And they picked this. They wanted to do this as the program name. And so the idea here is really a patient-centered medical home for hereditary cancer care. And so essentially the patient has a quarterback, an MD, an APP, that they're funneled in through either our clinical genetics service, some of the other referrals, oncology or surgery. Once they're mutation positive, they come into the program. We have their coordination of care, anything we can't order ourselves, like a procedure that we're not credentialed to do, we'll order the procedure. The idea is to minimize the amount of individual doctor visits that these patients have to go to, because they get very tired of always going to the doctor. And when they get very tired, they get irritated, and then they stop going. And that's what we have to be very, very mindful of. And so the other thing that this has allowed us to do is to establish a genetically high-risk cohort for not only data tracking, but for research. So the patients are informing the research, and the researchers going back in to inform the clinical care, which is really, really nice and something that I'm quite proud of. In terms of the program building, I think about this from an infectious disease standpoint, and I say this because when you think about viral transmission, this is like an R naught. They don't go anywhere. It's a gas. It continues to expand, and once you find these syndromes are autosomal dominant for the vast majority of them, so then you start getting their family members coming up. And so we looked at our numbers just from the last, looks like this is cut off from the 31st of 2024, so I have some updated numbers later to show you. And so you can see when I first kind of started this in 2019, it was just me. And I know someone in the room, it's just you. You will get there. And it's something where you find out very quickly, okay, here's my radiologist that I go to. Here's my oncologist that I go to. These are the people, and you set up a team and you figure out what is the team that needs to do this. And it really is a team-based approach. And so as this continued to build, then we started, looking at having nurse practitioner come in, have their own clinical focus. And now it's continuing to expand and kind of going beyond the scope of just one clinic. In terms of the underlying syndromes, so BRCA, certainly Lynch syndrome, and actually Li-Fraumeni syndrome are our top 3 syndromes that are followed in CATCH. We know Lynch syndrome and BRCA are relatively common in the grand scheme of things. They have long-standing screening recommendations. But how adherent are patients to these recommendations in Lynch syndrome? What data do we have? So this has been published on before, and it varies. These are some old papers. I can't believe 2019, I'm not calling old. But the Mittendorf et al. Paper in 2019, they showed that in Lynch syndrome patients, colonoscopy adherence recommendations were about 81%. Other recommendations varied significantly, as demonstrated by the violin plot here. They didn't see any difference when comparing patients that had a prior cancer history to those that did not. Prior to that, Elena Stoffel looked at this in 2010. And she found that personal or family history of colon cancer did improve their colonoscopy adherence. So it was 85% adherence rates to 60%. And again, that's at a tertiary center. These are not necessarily real world numbers. There's been some really nice data that's come out of the West Coast that looked at this in the Providence healthcare system and real world clinical practice, community-based centers, it's not this high. So we have a lot of work to do because the vast majority of patients or people in the US are not followed at places like MUSC and MSK. When you look at this in general, some of the best data on adherence rates is part of the prospective Lynch syndrome database. And this is the PSLD. And really what they showed for risk-reducing surgery. So as a reminder, women with Lynch syndrome are recommended to undergo risk-reducing hysterectomy and oophorectomy, depending on age, varied by gene now, but in general is something to remember, somewhere around 40 to 45, depending on the causative gene. There's a slight variation there. And you can see that uptake is still quite low. we looked at this. This is one of our medical students. He is now, gosh, he might actually be finishing residency now. But when he was initially looking at this, he wanted to understand what did it look like for us in terms of our colonoscopy and risk-reducing surgery adherence. And we had a 95% colonoscopy adherence rate. We didn't see any difference between the gene impacted or if they had a prior history of cancer. 90% of women that were recommended to have surgery completed the surgery. These are small numbers, keep that in mind. Among women that underwent this surgery, a third were found to have a precursor lesion at the time of surgery. So endometrial hyperplasia with atypia or something to that degree. So we knew that that surgery was important for them to have. So it was interesting. So he presented this at one of our collaborative meetings on inherited GI cancers in 2023. Li-Fraumeni syndrome, as a reminder, this is mutations in TP53. It's a diverse risk of cancers in both pediatric and adult patients. These are your core cancers. People really think about sarcomas and brain tumors. Has over a 70% lifetime risk of cancer in men and over 90% in women. The difference is really accounted for with the breast cancer risk. In terms of management, prior to 2011, it was, we've diagnosed this, good luck. Then Sick Kids, led by David Malkin, Anita Villani is the first author on this. She was his fellow at the time, looked at incorporating a very intense surveillance using whole body MRI, MR breast, MR brain, abdominal ultrasounds and biochemical screening that was age dependent to see if they could pick up cancers and really make an impact. They really only looked at 33 TP53 carriers in that initial study. 7% of these patients were diagnosed with new cancer. But the thing that was most striking and why the Toronto protocol has persisted as kind of the standard is that early detection of these tumors resulted in improved long-term survival. Updates in Li-Fraumeni syndrome is that we now know, just like in Lynch syndrome, it's not really all just Li-Fraumeni syndrome. This is a spectrum. There is really nice evolving literature, even some as published as recent as this past weekend, looking at this as being a spectrum. Not all TP53 is created equal. So this was one of the first studies that really looked at this in depth. This was Kratz et al. In 2021. They looked at over 3,000 persons from 1,200 families that were reported, evaluated genotype-phenotype, and tried to assign them as a spectrum. The idea being, could you potentially, based off of your genotype, tailor screening? That's the goal. That's what everybody wants to be able to say they can do. What was interesting about this is that they did find, when they were subdividing the analysis by those that actually had met Champre, I know the genetic counselors know what that means, but true clinical diagnosis of Li-Fraumeni syndrome versus those that did not meet criteria, to see did any unique variants kind of pan out. And they did see some unique variants, but they also found some hotspot variants in both groups. So it still wasn't perfect. This paper was published at the end of last year, so I think it was in November, where they were again trying to understand phenotypic stratification. And so now the idea, and what's really kind of the working language, is looking at, based off of the genotype and specific mutations, they have these clusters in terms of risk. So you have cluster 1, cluster 2, 3, and 4. And really your high risk mutations that seem to have the most severe classic LFS are these cluster 3 mutations. And then cluster 5 mutations seems to have an enrichment for osteosarcoma. If you haven't read this paper, I strongly encourage you to do so. If anything, you can download their supplemental data and see all of the variants, and then you can see, because they're all repeated variants, and you can get an idea of where your patients, if you have them, might fall along the spectrum. In terms of the CATCH 5-year experience, only about 15% of our patients met Champre criteria for testing for TP53. And that makes sense. The reason for that is that, again, we're understanding that a germline mutation in TP53 does not necessarily mean classic LFS. And so we know that there are hypomorphic variants now, and that's what that cluster paper is really getting at. One of those hypomorphic variants is what is called an Ashkenazi Jewish founder mutation. We have quite a bit of these. This is just the patients that I follow here at MSK. We have 37 patients with this particular variant. And it does seem to be lower risk, except for female breast cancer. In terms of what kind of pickups we've had in our patients, so about half of our patients with TP53 findings had at least one cancer prior to CATCH. We had 8% new cancer diagnosis using the Toronto protocol, which was right there with the Villani data. The thing that's most important to me is that 10% of our patients were diagnosed with their first cancer via CATCH surveillance, and all of these patients were diagnosed with early stage disease that was cured by surgery. So that was a big win for us. Now, going back here to this slide, updated numbers. So I just got these and I sent these to Alicia because I wanted to be 100% this, and this is new. So we have number updates. We have 250 TP53 positive patients at MSK. 130 or so I personally follow in the adult world, and we have 53 pediatric patients that are followed by my counterpart in our PEDS program, Shemin Kesserwan. MSK has a very large cohort of Lynch syndrome patients. We have about 1,700. This is our last cutoff. 1698 in our database. We have about 550 that are followed at MSK-CATCH. So we have a lot of these patients, and they're really helping to understand a lot of these research questions. So getting to establishment of genetically high-risk cohort, how are we doing this? So historically, we didn't really have, we were Memorial Sloan Kettering Cancer Center. We didn't really have a program or a place for cancer unaffected patients to just kind of plug in and have their care there. And not a lot of research kind of related to that. And we never had an institution-wide research protocol like MSK Impact that these patients could be a part of. So this is new. We've called it ENACT. So enabling research access to high-risk populations via biospecimen collection and data tracking. Acronyms, ENACT, whatever. It's fun, it's catchy. That's what we do in research. So the idea here is to establish centralized and standardized data resources for individuals with elevated cancer risk. They could be genetically, could be, my population, the CATCH population. These could be cancer survivors. These could be patients that had exposures, environmental exposures. There's lots of different things that could happen here. And the idea here is to really maintain a longitudinal repository of biological specimens, and be able to have a centralized repository for investigators at MSK to be able to link in, just like Impact, for these high-risk populations. So this is kind of a schema of how this works. So here's, when we're thinking of the patients that we're targeting, we have our behavioral and environmental risk. Anybody that had a precursor lesion like ADH or something to that degree, certainly genetic and familial risk, our cancer survivors. If they had their employer offered them, I'm not going to use company names, but offered them some sort of external cell-free DNA tumor screening that may or may not sound like a search for a holy grail, and they had a positive screen, but they don't know what it is. They come in. Diagnostic workup. Here's you're come in, there was an outside scan that read something. We don't know what it is. It hasn't been biopsied yet. Until it's cancer, we can put them on here. And the idea here is to really try to answer research questions in these elevated risk individuals. What are barriers to care? What are differences? Can we see some health disparities in outcome research in here? And also doing, what I'm very interested in, that's translational studies with cell-free DNA or things to that degree. The study design is actually quite unique for us. So this is done through a read and sign self-guided consent that gets pushed out to Epic. So the patients are identified as being candidates for the protocol. They get offered the read and sign consent through Epic, pushed out, they read it, they go through. It does not have a consenting professional signing it on the back end. The idea is just to make this as easy as possible for them to consent for it. So they're going to be coming through high-risk clinics, certainly CATCH. The clinic is actually who is determining whether or not they're eligible for the criteria. They do their consent. If there are biospecimens as needed, depending on investigator uses, we'll collect those, and then we'll have the centralized repository for analysis. The idea here is for researchers to be able to work under one umbrella and not have to put in multiple IRB protocols to work in these patients. So this is the study that many of my CATCH patients are now, in the work that I do, being consented to. And so that brings me to this question. With our surveillance, can we further improve protocols with liquid biopsy? So there are many of these commercially available cell-free DNA, ctDNA assays, and they really look at different things. So this is just this is probably old now, but different types of things that can be looked at in circulating tumor DNA or cell-free DNA. In patients with cancer, the idea here is to monitor for treatment response, assess for cancer recurrence, and we now know that different assays may be better suited for different uses. There's not a lot of work in this in patients, at least published yet, in patients with genetic risk for cancer. All of the data that's out there right now is really in presumed general population. This was the first. Again, this is from Canada, looking at Li-Fraumeni. We wrote the editorial on this when they put this out. And it was really trying to understand, can we augment whole body Toronto protocol screening in Li-Fraumeni to really understand and enhance our pickup rate? And so what they found in their analysis here was that they were obtaining at the time of whole body MRIs, they were getting plasma and then doing cell-free DNA analysis. And in patients that had active cancers, they already knew that they had cancer, but they were undergoing long-term surveillance because you still have to monitor them for second cancers because they get a lot of cancer. They saw a cancer signal in about 80% when they used any combination of 4 different assays. 4. So one is not going to work. And that's why in some of the literature and some of these commercially available products for cancer screening, the positive predictive value, I think the most recent in the Pathfinder study was 38% positive predictive value if this is truly cancer with a positive test. So even in high risk patients, it takes a combination. When you look at early stage disease, that signal decreased to 50%. So it's like flipping a coin. So it got you to a positive predictive value of about 54% overall. So then that got us thinking, what about for Lynch syndrome? Is there something unique to Lynch-associated cancer that we could leverage in cell-free DNA? Is there a pan-cancer signal that can be detected in the blood? Well, I told you there's a pan-cancer signal. We just didn't know if it was able to be detected in the blood at the time. So since colonoscopy is the only proven effective screening for Lynch syndrome, despite this being pan-cancer, perhaps we could leverage MSI as a way to screen for Lynch-associated cancers, regardless of the underlying tumor. And so we've been working on this for quite some time. You can call MSI, and MSI is now part of a fair number of commercially available cell-free DNA assays. You can call it. The problem with all of this, and this is what this graph is showing, is basically if you can find the variants in the blood, you can find the MSI. That's essentially the take-home message of both of these plots. Higher burden of disease, higher signal. We know this. It's the same thing with MSI. Really, the issue is always going to be with these cell-free DNA assays in the blood is tumor shedding into the blood. There are certain tumors that don't shed as well into the peripheral circulation. And I know from my family medicine training and OB and genetics that there are certain things that impact your ability to detect cell-free DNA. And that's from the whole, obstetrics world in using screening for women that are doing non-invasive prenatal testing. There are things that can compound and confound your ability to detect, Down syndrome, trisomies, those kinds of things on those assays. Things like obesity, things like diabetes, it all impacts it and has nothing to do with cancer. So then my thought was, well, if we can't detect a signal in the blood, what about other sample types? Is it simply something as easy as getting a little bit closer to the specimen, but still non or minimally invasive? And so this is something I've been working on for several years now. And just as by way of background, the Pap test and in general, all cervical cancer screening, regardless Pap or HPV only, all of those, major success story in women's health. From the Pap in general, it's somewhat minimally invasive. It's not pleasant, but in the grand scheme of things, it's screening for cervical cancer is standard of care by some way in women of over 21. It's not effective screening for endometrial or ovarian cancer. What has been tried, it was an assay that was published in several years ago now, called Pap-Seq, where what investigators did at this time was they used basically an endometrial biopsy, not quite as bad as a Pipelle biopsy, but something called a towel brush, where they still have to actually do invasive sampling. and do genetic sequencing to see if they could detect uterine cancers. And they could. So they could detect 80% of endometrial cancers when assessing mutations in cells. That's been published. But my hypothesis here is, well, if cell-free DNA is shed into the blood, it's probably shed into cervical mucus. Can we try it? And so it can be. So that's the hypothesis here, is that can you extract cell-free DNA from endocervical mucus and potentially detect tumor mutations there? And so that was the real question, was in women with endometrial cancer, can you detect their tumor mutations, and can you detect MSI status on endocervical fluid? And how would this compare to a paired blood test? And so that's what we did, and I presented this at ASCO this last year. We looked at patients with endometrial cancer that were undergoing surgical cancer care. We also looked at patients with Lynch syndrome just as a cancer-negative control that were undergoing presumed risk-reducing surgery so that we could interpret the data. We did paired plasma and endocervical samples collected at their time of surgery, extracted the ctDNA, looked for mutations, copy number variants, and MSI status, and then compared the results from both sample types to their tumor in the endometrial cancer affected patients, because they're all getting their tumor sequence. So we want to see, we have the tumor, let's look at the tumor, let's look at the blood, and let's look at the endocervical fluid and see if we can see these mutations and if one is better than the other. In terms of our cancer affected patients, a couple of key parameters here. This was a pilot study just to kind of test this out. We had, the age of diagnosis here in the overall group. These are 16 patients. So again, small study. The average age was about 60. Those that had low risk MSS tumors, the average age was about 54. If they had a high risk endometrial cancer, MSS endometrial cancer, they were a little bit older. And then our MMRD endometrial cancer is quite interesting. Again, these are very small numbers. They were a little bit older too. This is our ancestry breakdown. We actually have now genetically imputed ancestry on MSK-IMPACT. It's no longer self-reported, so all of our data that is coming out of IMPACT is based off of using SNPs to impute ancestry. Most of these patients were never smokers. Most of these patients were overweight or obese, which is a known risk factor for endometrial cancer, which is very important when you're trying to do cell-free DNA analysis in the blood, because that impacts your ability to detect it. In terms of their tumors, over half of these patients had low-grade endometrial cancer, so early stage, low-grade. We had 2 low-grade endometrial tumors that were MMRD due to somatic MLH1 hypermethylation, because we don't know these patients' Lynch status at the time that they undergo surgery. 81% of our tumors were stage 1 or 2. In terms of our yield, we had practically a 5-fold increase yield in cell-free DNA and endocervical fluid. When you look at this by sample type, these are all of our individual patients here. You can see in general, pink is what we're looking at, or the total number of nanograms of cell-free DNA extracted. What we do to confirm that this is cell-free DNA, we do fragmentation analysis. Cell-free DNA fragments tend to be much smaller, so that you can then see this is truly cell-free DNA. So we have it's a robust sample type. We were able to detect mutations at much, much higher levels in our endocervical fluid, even in our early and low-grade disease. So just to orient you to this plot here. So here, our most commonly mutated gene in the tumors was P10. This is just a heat map. You can see this. And basically, I'm comparing our tumor to our endocervical to our plasma. And you can see all this dark shows all these mutations that are missed in the plasma, whereas the PAP looks much, much more like the tumor. So we detected mutations in 93% of our endocervical fluid, but only 1/3 of our plasma. In tumors that were detected in both assays, the variant allele frequency was much higher in the endocervical fluid versus the plasma. P10, not surprisingly, was the most common mutated gene overall, but we did have some variability by histology type, which I'll show you. And our 3 negative controls, which were germline Lynch, did not have cfDNA positivity in either sample type. You can see that our most commonly mutated genes did vary a little bit by the type of histology type in these 3 buckets: the low-risk MSS, the high-risk MSS, and the MMRD. This is just kind of using the FIGO classification. Of our MMRD cases, you can really see plasma just really didn't get them at all. We also were able to call MSI on the endocervical fluid, but not on the plasma. So that's really important in terms of treatment decision. In looking at some very interesting cases here, this right here on the left is a grade 1, stage 1 endometrioid low-risk MSS tumor. This is her tumor tissue. So these are individual mutations that are listed here. And you can see we ran this on both of our impact platforms, and then we have our own institutional cell-free DNA platform called Access. So we ran both of these, and you can see that we just had very, very strong hits on our endocervical sampling versus just the plasma. The same thing in our high-grade, high-risk disease. The cell-free DNA in the endocervical fluid or PAP, whichever you want to call it, just looks so much more like impact tissue. And you can see with this correlation with our Pearson R that these mutations is just strongly associated. So it's really nice and compelling work. We have a long way to go, but it's really nice. Among the patients that had the early stage disease, again, it was 13 patients, 92% of them had positive cell-free DNA on the endocervical fluid. Only 23% were positive on the plasma. In late stage or high risk disease, the VAF of mutations in the endocervical fluid was similar to that of the tumor tissue, which was really profound. Again, I think it's just proximity. So final thoughts. Hereditary cancer syndromes are complex. Surveillance recommendations evolve as more data is generated. Not all Lynch syndrome is created equal. Consider the causative gene and patient age and medical comorbidities when you're thinking about how to take care of them. Li-Fraumeni syndrome is likely a spectrum of disorders. There are many evolving research questions in this population in terms of genotype, phenotype. Like I said, the paper just published this weekend. Cell-free DNA is promising technology for high-risk populations, but it is likely going to require multimodal approach in assay as well as the sample type. So with that, thank you all very much. These are my acknowledgements, our funders, my team, mentors, collaborators, and happy to answer any questions.
Can you talk a little bit more about what you're doing on the peds side for research?
Yeah, so in terms of for pediatrics, we are, so that ENACT protocol right now, because it's a read and sign consent, we initially included peds in the IRB pushback. So because they were concerned about the ways in which we're consenting. So that is the next wave, once we can prove that the adult, that is read and sign is not scary when you're just looking at collecting specimens and showing that the parents can do that. So that's going to be the next wave from that side of it. Shemin Kesarwan is my counterpart in pediatrics in our CATCH program. And so she's really interested in collaborating with me on a lot of this work. We're doing a lot of these cell-free DNA collections in particularly our Li-Fraumeni syndrome patients, both in adults and peds. And so that is happening. So a lot of that work we are collecting. In terms of, management of these syndromes, she does the clinical management. And then we have multiple grants, both in her grant, external funders and grants with collaborative efforts with Sick Kids in Toronto, looking at vaccine development and in Li-Fraumeni syndrome, which is really cool. HLA phenotyping, which is primarily geared towards pediatrics to try to do vaccine development for cancer in that cohort. That's a huge initiative. It's just starting. I think there's like 200 investigators involved as part of that, but I'm site PI for that. And then she's leading the effort for peds.
You have an online question. It says, thank you for an excellent presentation. What are your thoughts on patients who fit clinically phenotypic criteria for having a familiar genetic disorder, but test negative, such as the majority of young onset colorectal cancers, and so many others who are young and have a convincing family history? How are these patients being studied at MSK-CATCH?
Clinically, I follow a lot of them. So if they come through genetics, so a lot of those patients that are germline negative, but there is something there. In terms of the clinical management, often they're looped in. We'll have like an approach, whether it's straight with me if it's something that, we have several of our patients that meet Champré criteria for Li-Fraumeni syndrome, but we cannot find the TP53 mutation. So I'll follow them and catch. And then we have, in terms of the research questions related to that, looking at, increasing utilization of different types of genetic testing to try to increase your yield. So things like RNA, trying to look at long-read sequencing. We're partnering with an external lab to try to enhance some data and calling for that. And then also looking at genetic modifiers of risk and polygenic risk. I think a lot of our early onset, at least when you're looking at from the genetics perspective, it's not single gene. I think that there's going to be something else there, whether it's polygenic, environmental, something to that degree. But this surge in early onset colorectal cancer, it's not Lynch syndrome. It's just so we do follow those patients. We have for colorectal cancer, we have a center for early onset colorectal cancer that is followed. If they're genetically negative, then they kind of live within that bucket. For those that test positive for Lynch or other syndrome, they usually send them to me. We don't let them go. Those are the ones you worry about. Those are the ones you lose sleep over.
For a lot of the variability you see with Li-Fraumeni, do you think that also could maybe be related to mosaicism? Like, so for example, like I'm thinking of one particular patient I had who I think had, low risk, intermediate risk prostate cancer in like his 70s. Did germline testing, he had a TP53 mutation with a lower VAF. We did a skin punch biopsy and it was present. He didn't meet any Champré criteria. And I know,
Sorry to put you on the spot.
Say that again.
You know the variant?
No, but I can get back.
Send it to me.
Variant. And it's just, it's just hard to, with those patients because, like as the workflow goes, we should follow them as if they have Li-Fraumeni, but I don't know if you think maybe that has anything to do with the variability.
So he was mosaic, but you confirmed it in the skin?
So I'm trying to, I need to, this was like 2 years ago, and this whole process took like 8 months to get this whole thing sorted out. I cannot remember the exact VAF that Invitae gave me. We did the skin punch at GeneDx. It actually was a VUS at GeneDx, but pathogenic at Invitae. But yeah, it was confirmed in the skin punch. But all he had was like intermediate risk prostate cancer in his 70s. I think he had a grandparent with bladder cancer, and that was pretty much it. So
Do any cascade testing?
I believe his sister, he doesn't have any biological children. I believe his sister got tested, but I do not know the status. He has 2 sisters. I only know of one of them that was getting tested, I think in Ohio or something.
So the trick with TP53, it's the most commonly mutated gene in cancer, right? And then on top of that, you're getting a lot of these external labs that are reporting CHIP, and it's not necessarily Li-Fraumeni. And on top of that, the hotspots in CHIP and somatic and germline are all the same. So it's complicated. I think in that case, we definitely have patients I have patients that I follow that have TP53 mutations in their 70s, had some random cancer, but they had the Ashkenazi Jewish founder variant. It was a man. I have a couple of those. And so really, this is where I have very open and honest conversations with them about it, what is the utility of this? What are your goals? What do you want to do? And try to counsel them, because that's not, I'll tell people full stop, you don't have Li-Fraumeni syndrome. You have a germline mutation in TP53. Yeah. I have to diagnose you with Li-Fraumeni syndrome if you want insurance to cover your whole body MRI. But that's the conversation that has to be had. I think in the next 5 years, we will be able to really have that tailored surveillance recommendation based off of genotype-phenotype, because it's very striking in TP53, and we are very close to doing it. The problem is that it takes collaboration. We have a lot of Li-Fraumeni, but it's still only 250. So we have to be able, and that's not, you're not going to get statistical significance. Nobody's going to be comfortable saying in a, 250 cohort, I'm comfortable saying I don't need to do a whole body MRI and this, they're just not. So it requires collaboration across institutions, which there's, if you don't know about it, there's the Lift Up study. Do you know the Lift Up study? So Lift Up is, that's led by Judy Garber, Dana Farber, and then Steve Gruber at City of Hope. That is a wonderful resource. Patients can go and consent themselves if they go to liftupstudy.org, and they can be a part of that. And the idea is to set up a network and a repository of TP53 variants, whether it's VUS, LP, whatever, to really try to answer these questions. So a lot of the data that I showed you today is because of Lift Up. Yeah, it's a good one. Yeah. Yeah.
Just related. With TP53 mutations, are there any other mutations like near that Ashkenazi Jewish hotspot that also have like that same phenotype, or is it really just that one variant?
Yeah, so it's tricky. So that paper that I showed you with the clusters, that's going to be the one that you really want to look at and try to understand. It all depends on where in the gene they're kind of hitting. So DNA binding domain is really important. And so anything within the DNA binding domain typically has a higher risk, and you have more propensity of developing that classic phenotype. So it's plus minus. That particular variant does seem to be somewhat unique in terms of understanding, lower risk. Having said that, we still have families that have, and this is a research question that I'm looking at now, because we probably have the most with that variant simply because of geography. We're in New York City. So it's very interesting in that we do have families that grandma is positive. She had breast cancer at 60. Mom is positive. She's fine. Child is positive, and he had adrenal cancer. What is that? So I think there's a modifier. So there's been some really nice data that looked at the Brazilian founder mutation, which is the most commonly studied mutation in TP53. And that data, actually, this is gonna make you smile a little bit. In Brazil, this particular TP53 mutation is on their newborn screen because it's so prevalent. Yeah. Yeah. It's very prevalent. And they have an increased enrichment for very early onset adrenal cancer, like infancy. So there's a modifier that was described several years ago. There's a different gene called XAF1 that if a patient with the Brazilian founder mutation, a Brazilian patient with Brazilian founder also has a co-mutation in XAF1, they present with a severe phenotype versus if they don't. So yeah, so then the question then comes, well, could it be something similar in other founder variants? So we're looking at that too. Thank you, guys.